Start.
Is it? It's going live?
Please start.
Is it going live?
Yes.
Have you seen it?
Yes.
Fine then.
No? No.
No, it's not. Now it's fine. You can go ahead.
I got it. I saw it.
Yeah, fine.
Good evening, everyone. It's my pleasure to invite you all to ISA National Online PG class event. These classes will be held on every Monday at 6:30 p.m. I myself, Dr. Lavanya, working as consultant in Sunray Hospital at Anantapur, AP. I will be one of the screen coordinator along with Dr. Farin for today. So today's topic is on the basics of mechanical ventilation modes. As we are beginning this session, I would like to briefly quote what Andreas Vesalius, who described mechanical ventilation: an opening must be attempted in the trunk of the trachea into which a tube of reed or cane should be put. You will blow into this so that the lung may rise again and the heart may become strong. Mechanical ventilation forms a mainstay of critical care in patients with respiratory insufficiency in day-to-day life. So with this being said, let us commence this session by invoking the blessings of the divine Lord Ma Saraswati. Now, since we have invoked the blessings, may I now request Dr. Sukhwinder Singh Bajwa sir, our ISA National Honorary Secretary, to address the audience.
Thank you, Dr. Lavanya. First of all, I think Dr. Subodh needs no introduction. He's a master class teacher from India, taking the teaching to a different level. The way he teaches, you will enjoy this class. And more importantly, the topics chosen by him is one of the topics which has advanced, I think, over the last 2 decades, right from the beginning when we were doing the PGs, the modes were 3 or 4 modes. And over the years, so many modes have come. But when you enter into the post-graduation and you are doing the PG and then you're doing the researchships or even the clinical work, sometimes it's become very difficult to choose the exact mode according to the patient age, gender, the BMI, the respiratory condition, the cardiac condition, and so many other factors are there, which makes it very difficult to exactly choose which type of mode is best suitable for that particular patient. So many clinical scenarios are there. We will not be touching those clinical scenarios in advance here, advanced basics mode of ventilation. Rather, we just stick to the basic today in this class. It's a very, very important and essential to know almost everything. So I think it will be an interesting class. Everybody should enjoy this class today. So I request Lavanya to take over the things from here.
Thank you, sir, for your kind words. Now I invite my co-screen coordinator, Dr. Farin Rahat, to introduce the faculty moderators and also to outline the session and rules and carry the session forward. Over to you, Dr. Farin.
Good evening, everyone. My name is Dr. Fareen Rahat. I am currently working as Senior Resident, KMCT Medical College, Calicut. It is my pleasure to introduce our esteemed faculty for today's session on basics of mechanical ventilation. Dr. Subodh Chaturvedi, popularly known as Clinical Guruji. He is a senior consultant in anesthesia and critical care with 20 plus years of clinical experience. He has conducted more than 10,000 cardiac and 6,000 bariatric procedures. He is the founder of Clinical Guruji, India's largest medical skill upgradation platform. He has trained over 1,25,000 doctors in emergency and critical care skills and has also been a featured educator on Times Square, New York, with 1 million plus followings on YouTube and Instagram. He has special interest in resuscitation technology and artificial intelligence. A warm welcome to you, sir. Now, I would like to briefly share the rules for today's session. Firstly, you all will be kept muted throughout the session, and please keep your videos off during the session. Secondly, if you have any queries during the session, you can type them in the chat box and all your queries will be answered at the end of the session. Now, I request today's faculty to take over the session. Over to you, sir.
This is going to be an interactive class. I'll keep watching the chat box all the time. So can just anybody type that they are able to listen to me if I'm audible enough or not? You have
Yes.
to keep typing in the chat box all the time.
Screen coordinators will be helping you.
Yeah,
Dr.
wonderful,
Awasthi
wonderful.
and Dr. Rahat.
Yeah, right, sir. Fair enough, fair enough, fair enough. Right. So let's start with the story. You remember this guy, a naughty boy. He didn't improve over all those years. He became old and still he was the same. He was a cheater, and one fine day his wife beat him up with a baseball bat. This guy has come to your ICU. He is semi-conscious, disoriented, breathing shallow. You are handling the ICU, and this guy has a respiratory rate of 6, a saturation of 88%. What will you do? These are your options. You can write ABCD or you can write whatever you want to. I'll wait for your answers. The guy was hit on his head. He's breathing slow and shallow. His respiratory rate is 6. His saturation is 88. What are you going to do? Chat box. Write down. You are going to be typing all this 1 hour. Right, put him on venti, PSV, very good, wonderful. C and D, C and D, 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 C, C, D, D, C, D, C, D, C, D, C, D. So nobody is giving him oxygen, his saturation is low. Okay, fine, nobody is putting him on BiPAP. Okay, see the invasive ventilation, why? B, yes. Nobody is giving oxygen. Right, so we'll answer that. We'll answer that in a short while. I'm Dr. Subodh Chaturvedi. I run a platform called as Clinical Guruji, and I try to simplify things. This is a quote from Kabir Das ji. He says, "Main kehta surjhavan hari." Somehow, our medical education has been rendered too complicated. It almost seems like that the books don't want to teach you. They somehow want that you don't learn. So I try to simplify things. I try to make things easier for you, and that is why I'm running this platform, which is called as Clinical Guruji. I have an Android and iOS app, and one disclaimer that I teach professionally. I sometimes charge money for teaching. So the disclaimer is that after this class, if you end up purchasing something from my website, then I'm not responsible. So coming back to our case, this guy is breathing slow and shallow. His respiratory rate is 6. His saturation is 88. What will you do? So most of you are writing either ventilator on PSV mode, or you are writing ventilator on CMV. Unfortunately, most of the answers are wrong. So let's begin with the basics first. इंसान की जिंदगी में there are only two problems. ये हिंदी अंग्रेजी थोड़ा मिक्स चलेगा. Everybody can understand Hindi ना. I'll speak in English, but sometimes I might switch over to Hindi because my default is Hindi. A person has only two kinds of problems in his life. One is oxygenation, and other is ventilation. Oxygenation means oxygen goes from atmosphere into your bloodstream. Ventilation means CO2 going out of your bloodstream into the atmosphere. Now you tell me, what was this guy's problem? Is it oxygenation or is it ventilation? I'm waiting. What is this guy's problem? Is it oxygenation or is it ventilation? Now somebody is writing both, but then what is the primary problem? Has anything gone wrong with his lungs? I don't think so. His problem is ventilation. And since his problem is ventilation, we cannot give him only oxygen, right? Because oxygen will work only when he's actually breathing comfortably. If he's generating enough minute volume, if he's generating enough tidal volumes, then only oxygen will help. His problem is not with his lungs, his problem is with his breathing. Right, fair enough. Why not BiPAP? Somebody wrote BiPAP. Why not BiPAP? My answer will be C. My answer will be, for this question, my answer will be CMV, this one. So why not PSV? Why not BiPAP? Now there are two things in breathing. One is सांस लेने की इच्छा and the other is सांस लेने की ताकत. Educated people call it as trigger and efforts. The problem with this guy is with his triggers and efforts both. Oxygen supplementation is needed when a person is having trigger, he is having efforts, but somehow his lungs are not helping him and he is getting desaturated. Somebody with maybe ARDS, somebody with a pneumonia, somebody with COVID. He is having trigger, he is having effort, but his lungs are not supporting, his alveolo-capillary membrane is damaged. So this guy needs oxygen. Somebody who has our Baba has less trigger and less power. Somebody who is hit on head, he is not breathing enough, he is not having a good tidal volume, he is not having a good respiratory rate, he doesn't need oxygen. Why not BiPAP? Why not BiPAP? Because he doesn't have trigger also. His respiratory rate was 6. He is not having efforts, he is breathing shallow, he is not having triggers, his efforts are less, his trigger is less, that's why he will need ventilation. Not oxygenation, not BiPAP, not PSV. He will need full CMV ventilation. Again, coming to a little basics, how we breathe. We breathe by taking in the air. Whenever you ask somebody, whenever you put a stetho and you say, Baba, ek lambi saans khicho. When we breathe naturally, we breathe in the air. We suck the air in, it is called as negative pressure ventilation. While mechanical ventilation is exactly ulta. It is positive pressure ventilation, it pushes the air in. So for all practical purposes, mechanical ventilation is a sophisticated, educated ambu bag, nothing else. Agreed? So what we have learned so far, that there are two kinds of problems. One is oxygenation and other is ventilation. Oxygenation means that the oxygen is not going in. Ventilation means that the CO2 is not going out. For oxygenation and ventilation, you need two things: effort of breathing and trigger of breathing. This guy, if somebody is having trigger but not efforts, like somebody maybe with Guillain-Barré syndrome, maybe somebody with myasthenia gravis, if somebody is having trigger, he wants to breathe, but he doesn't have enough power, then he will work with BiPAP also. But if somebody who doesn't have trigger and efforts will need proper mechanical ventilation. Fair enough. So what will be your first mode of ventilation for this patient? So we have ruled out oxygenation, we have ruled out BiPAP. We'll put him on ventilator. What will be your first mode of ventilation? I would like to see the chat box now. CMV, ACMV, PSV or SIMV plus PSV. Show me. Okay, 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 okay. Okay, so maybe we'll decide after we learn all these four modes, then maybe I can ask you again and you can tell me what will be your first mode, right? So continuous mandatory ventilation is by definition, ventilator delivers a preset number of breaths with fixed tidal volumes or pressure, independent of patient's breathing efforts. The key features are controlled breaths and I don't know, blah, blah, blah. If I had to teach like that, then I won't like to teach you and you won't like to learn from me. So let's take it to a different dimension. Let's make it a little Bollywoodia style and let's learn this ventilator in a totally different way. So the patient has gone to not your ICU, but in an ICU at Vasepur. And Dr. Ramadhir is on duty. Now Dr. Ramadhir has to ventilate him. Unfortunately, Vasepur is still quite behind in development. When I used to study like 25 years back, those days the hospitals, our hospital, didn't have a lot of ventilators. Even if they were there, they won't be working. So what we used to do, if a patient is not coming out of anesthesia, we will give an ambu bag to the attendant and we'll ask him just like Sholay style, jab tak tere haath chalenge, tab tak iski saans chalegi. And most of the time, the patients would make it. Similarly, in Ramadhir's ICU, there is no ventilator. All he has is a 10th fail boy. And you would be surprised to know that ventilator is also, for all practical purposes, a 10th fail boy. It is just a machine with intelligence of a 10th fail boy. You can tell him what to do and it will do exactly what you ask him to do. So Ramadhir Singh asks the person that you have to ventilate. And unfortunately for the patient, this is the 10th fail boy who is going to ventilate the patients. Do you know who he is? Do you know? I hope most of you know him. ये चैट बॉक्स सामने दिखता तो अच्छा होता है. You know the guy? Anybody? So yeah, this guy is perpendicular and he's supposed to ventilate our patient. Now this perpendicular URF ventilator asked two questions before ventilating the patient. First one was कि कितनी हवा डालनी है पेशेंट में, how much volume of breath to give. And second was कितनी बार हवा डालनी है. Got it? The ventilator asked two questions. Primitive ventilator. In Ramadhir Singh's era, it asked only two questions. कितना volume देना है, how much air to give, and how many times to ventilate. Fine, we know the default answers. We told him that the patient's weight is 60 kg. Now, can you tell me how much air to give in a 60 kg patient? Let's say it is his ideal weight. He's a fit guy. How much breath to give? How many breaths and how much tidal volume? Default settings. So this guy is kind of unconscious. And what we need is, we need to remove his CO2. We want to wash off all his CO2. And to wash off his CO2, we need to give a fixed minute ventilation, because CO2 depends only and only on one thing, that is minute ventilation. So we need to give him a fixed minute ventilation. How much minute ventilation do we give? The calculation is very easy. You just put a zero after, you just put a dot in between his weight. Like his weight is 60 kg. So you give him 6.0 liters or 6000 ml of minute ventilation. Fair? Now, how will you give 6 liters of minute ventilation? You can maybe give 600 into 10, or maybe you can give 500 into 12, or maybe you can give 400 into 15. So we choose one of that. We'll choose maybe, what is the commonest? Let's say 400. Everybody is writing 420 to 480. So let's say 500. So we ask this perpendicular guy to give 500 breaths, 500 tidal volume and 12 breaths, a total of 6 liters per minute. He started ventilating without caring for anything. He is perpendicular, he is 10th fail, he doesn't know anything, he will do exactly as told. The ventilation mode is called as continuous mandatory ventilation. Right? So what does the mode do? It gives fixed tidal volume at fixed rate. All breaths are delivered by the ventilator. The tidal volume is fixed, the minute volume is fixed, and the rate is fixed. And there is no respect for patient's efforts. So our perpendicular took an ambu bag and he started ventilating the patient like this. Look, ambu bag hai mere paas. So this perpendicular guy, he took the ambu bag and he started ventilating. 500, 500, 500. 500 into 12. So every 6 seconds or every 5 seconds, 12 pange 60. So he will give one tidal volume every 5 seconds. What he will do? He will count 1, 2, 3, 4, 5, 1 breath. 1, 2, 3, 4, 5, 1 breath. All he is doing is 500 tidal volume into 12 breaths. Now, Baba got his CO2 washed out. Baba became awake again and Baba started breathing. But then what happened? Baba is trying to breathe out, but perpendicular is giving air. Baba is trying to breathe in, but perpendicular doesn't care because he will give breath only after 5 seconds. So all breaths are delivered by ventilator. The tidal volume is fixed and the rate is fixed, and there is no respect for patient's efforts. There will be eventually patient ventilator dysynchrony. Now if Baba is trying to breathe out and you give him breath, what will happen? His lungs will inflate like this. They will start compressing his chest, his heart, and the Baba will go into hypovolemia. The Baba will go into hypotension. This mode was very uncomfortable for our Baba despite saving his life. So this mode was continuous mandatory ventilation and it was good but very uncomfortable for the patient. And there is only one place where this mode should be used. And what is that place? Can you tell me? There is only one place in this world where this mode has to be used. Now even the modern ventilators, ICU ventilators, they have removed this mode. It has to be given only where we use it. So first mode was CMV. It was an ancient mode of Ramadhir's era where the patient will get fixed tidal volume and fixed rate. So far so good. Right. So now Ramadhir Singh was very unhappy with perpendicular. That okay, fine, the patient is breathing, he's alive, but he's very uncomfortable. He's going into hypotension because there is gross patient ventilator dyssynchrony. Perpendicular was called again. गलत ventilate कर दिया तुमने. Then perpendicular asked 3 questions this time. Previously it asked 2 questions. कितनी हवा डालनी है और कितनी बार डालनी है. This time he asked कितनी हवा डालनी है, कितनी बार डालनी है और सांस कौन देगा. Who will trigger the breath? Now let's understand the concept of trigger. What exactly is trigger? Now the breaths can be started by the ventilator or the patients. There can be only 2 types of triggers. Either the patient can initiate a breath or the ventilator can initiate the breath. When the ventilator is initiating it, it can do it only on basis of timing. The ventilator can initiate a breath only by counting seconds. 1, 2, 3, 4, 5 breath. 1, 2, 3, 4, 5 breath. A patient can trigger it by trying to suck the air in. Okay, let's explain it further. There is some amount of air flowing through the ventilator circuit at all times. Now I told you in the beginning, in the basics, that whenever we breathe, we try to breathe in. Mechanical ventilation is just ulta, it tries to push the air. So if a patient will try to breathe naturally on ventilator, what he will do? He will try to suck some air in. And the moment he tries to suck some air in, there will be a negative pressure generated in the ventilator circuit. This negative pressure generated by sucking in of air during patient's efforts is called as a trigger. So a patient can trigger a breath by sucking air in, but the ventilator can trigger a breath only by counting the seconds. One is called as time triggered and the other is called as flow triggered or pressure triggered. Now this sucking in of air can be measured either through the decrease in flow or decrease in pressure. You must have set 3 liters ka trigger or 2 liters ka trigger, yeah, pressure trigger of -3, -2, -5, whatever. So trigger can be of 2 types, ventilator triggered or patient triggered. So this trigger looks like this on a ventilator graph. This is your trigger. This is a volume controlled mode graph. This is trigger. Then this is a pressure controlled mode graph. This is the trigger. So now he was asked to do a different kind of mode. कितनी हवा डालनी है, we will tell you. कितनी बार डालनी है, we will tell you. And every time the patient will trigger a breath, you will give a full tidal volume breath. This mode was called as ACMV or assist controlled mandatory. The ventilator was supposed to give breath on every trigger by the patient. What is the difference between CMV and ACMV? In ACMV, every triggered breath is also given full tidal volume. In CMV, only the fixed tidal volume, only fixed number of breaths will be given irrespective of what patient does. In ACMV, all triggered breaths will be given full tidal volume. So the ventilator will be giving mandatory breaths 500 into 12 plus the patient can initiate a breath, but then the ventilator will take over and deliver the predefined tidal volume. So what will happen? Let's say a patient is kind of unconscious. The ventilator is giving breaths 500 into 12. One breath every 5 seconds. 1, 2, 3, 4, 5, 500 ml. 1, 2, 3, 4, 5, 500 ml. 1, 2, 3. Patient tried to gasp. again 500 ml. 1, 2, 3, 4, 5, 500 ml. So every time the patient is triggering a breath, the ventilator is giving 500 ml, and when patient is not triggering a breath, ventilator is giving 500 ml every 5 seconds. So each mandatory breath and each patient triggered breath is given same tidal volume. But these breaths are not truly spontaneous breaths. They are just initiated by the patient, but then the ventilator takes over. Now, what is the risk with this kind of ventilation? It was better than ACMV. The patient will get a breath whenever he wants. But then, what is the risk with this type of ventilation? Tell me. Tell me in the chat box. What is the risk with ACMV? Now we are giving 500 into 12 and we are assisting every triggered breath also. Yes. Wonderful. Hyperventilation. The CO2 will get washed out. And yes, volutrauma, hypocarbia. Wonderful. So I am teaching fine so far. So if you have understood it so far, please write something in chat box so that I'll know. If you understood these two modes, CMV and ACMV. Right, ठीक है. So this time again, Ramadhir said, कि no, this is not working. Let's respect every breath of patient. Fine. You are giving volutrauma, you are hyperventilating the patient. Let's not do that. Let patient breathe on his own. So this time the mode was defined as pressure support mode. Now the patient, the ventilator or the perpendicular guy was told to sit idly and wait for the patient to trigger a breath. जब तू सांस लेगा तभी मैं सांस दूंगा. The mode was called as pressure support mode, PSV. Now what is the difference? All breaths have to be triggered by the patient. The ventilator is sitting idly. 1, 2, 3. Patient triggered a breath. Ventilator will give a predefined pressure, not tidal volume. The ventilator will generate some amount of pressure in the patient's airways. Get me right? Previously, the ventilator was giving a fixed tidal volume. Now the ventilator is not giving a fixed tidal volume. It is just increasing the pressure of airway by a certain amount. Let's say there is a PEEP of 5 constant going on. The ventilator has been told to give 15 ka pressure support. So what will happen? The ventilator will wait. Whenever the patient triggers a breath, it will increase the pressure in the airway by 15. Every breath, it will increase the pressure by 15. That's it. How much tidal volume will be generated? That will depend upon how much effort the patient made. Right? So each breath is generated by patient only, first and foremost thing. Ventilator will give a fixed predefined pressure to the patient's effort. The respiratory rate and tidal volume, they will keep changing all the time. They will depend only and only on patient's wish. If the patient takes a deep breath in and ventilator gives 15 ka pressure, the tidal volume might go to 700. If the patient doesn't generate a big effort and the ventilator gives 15 ka pressure support, the tidal volume might go to 300 only. But these things will keep changing and everything will be defined as per the patient's efforts. This was a good mode because patient was absolutely comfortable. Whenever you see patient ventilator dysynchrony on your ventilator, do one thing. Maybe put him on PSV with a pressure support of 15 or 17 or something like that and observe what does the patient want. If he is trying to take too much air in, probably your flow is less. But then this is a talk for a different day. Right now, PSV, the pressure support mode, was a very good mode for weaning, for a awake patient, for a patient who can decide when he wants to breathe. So this is a very good awake mode, and this is used very much uh, in weaning along with SIMV. It is called as SIMV plus pressure support. So our boy put the patient on pressure support ventilation. All was going good, everything was fine. But then what happened, as it happens in our ICUs, that at night, maybe 2 o'clock, all these awake patients on ventilator, they keep asking for things. Their hands will be tied and they will just keep doing something, and they will ask for pani, they will ask for something, they will ask to be moved around or something like that. And a Chudal nurse, a wicked nurse, gave this patient some midazolam and some atracurium. The patient was on PSP. Those were the ancient days. The patient was given relaxant. Now what will happen? Ventilator is sitting idle. The ventilator is not generating any breath. It is waiting for the patient to generate a breath, and the patient is not breathing. What will happen? You all know what will happen. So Ramadhir called and said,
तुमसे ना हो पाएगा,
नहीं हो पाएगा.
हमें तुम्हारे लक्षण बिल्कुल ठीक नहीं लग रहे, तुमसे ना हो पाएगा.
Had a problem that it will work only in a conscious, oriented, spontaneously breathing patient. It won't work with unconscious patient, paralyzed patient. So eventually somebody else was called and a new mode was designed. The new mode was called as SIMV plus pressure support. Now this was best of both systems. It had the good features of ACMV and it had the good features of pressure support also. So what will happen? The patient will be allowed to breathe on his own. Okay, fine. The spontaneous breaths are supported with pressure support. Let's understand. This is a different situation. The patient is allowed to breathe on his own. The spontaneous breaths are supported with pressure support. And if the patient fails to breathe, then the ventilator will give him minimum fixed minute volume mandatory breaths. नहीं समझ में आया? I'll explain. Let's say we set up the patient with a respiratory rate of 12, a tidal volume of say 500 and a pressure support of 15. What will happen? First breath was delivered mandatory 500 ka tidal volume. Fine. First breath was delivered mandatory 500 ka tidal volume. 500. Now the ventilator will wait for 1, 2, 3, 4, 5 seconds. The patient did not make a move. Ventilator gave a mandatory breath of 500 ml. Again, 1, 2, 3, 4, 5. The patient did not make a move. The ventilator gave 500 ml. Then 1, 2, by the time 3, the patient generated his own gasp. Now the ventilator will sense that spontaneous breath and give what? 15 ka pressure support. This is a spontaneous breath. The ventilator will recognize it and give 15 ka pressure supported breath. So the mandatory breath tidal volume is fixed 500. The spontaneous breath tidal volume will depend on how much effort the patient generated. So the patient is getting a minimum of 500 into 12 plus all his spontaneous breaths are supported with a pressure support. Unlike ACMV, when all the triggered breaths were supported with 500 ka fixed tidal volume, In SIMV PS, the spontaneous breaths are given 15 ka pressure support. Are we together here? Okay. What is SIMV? Synchronized. Again, pehli breath 500 fixed tidal volume given. 1, 2, 3, 4, 5. No effort. 500 mandatory breath. 1, 2, spontaneous breath 15 ka pressure support. 1, 2, 3, 4, 4.5, and patient triggered a breath. At 4.5, patient is triggering a breath. Now the ventilator has to choose. Will it give 500 because of 5 seconds are finishing, or will it give 15 ka pressure support because it is a spontaneous breath? What it will do is, since this breath is coming very close to the time of a mandatory breath, it will recognize the spontaneous breath and give 500 ka tidal volume. It will synchronize the mandatory breath with patient's effort. Did you get it? So synchronized is when the spontaneous trigger is very near the timing of mandatory breath, the ventilator will synchronize the spontaneous and the mandatory breaths and will give 500 ka tidal volume to a spontaneous breath. Otherwise, if the breath is generated between the two mandatory timings, it will give 15 ka pressure support. So what is the difference between ACMV and SIMV? ACMV and SIMV, both the patient can initiate a breath. But in ACMV, as soon as the patient initiates a breath, the ventilator takes over and gives 500 ka fixed tidal volume. In SIMV, each initiated breath will have its own tidal volume depending on patient effort and pressure support. Did you all get it? Did you all get the difference between ACMV and SIMV and the philosophy of SIMV? I would like to see that in chat box. Okay. 3:1, 1. Right. So I'll explain the difference part. 2 or 3 people are saying, please repeat it once. In SIMV plus pressure support, first let's understand SIMV plus pressure support. We have decided 500 into 12. So every 5 seconds, one breath will be delivered. If the patient does not make any move, the ventilator will keep giving 500 ml ka tidal volume every 5 seconds. Fine. Let's keep it out of the picture now. If a patient initiates a breath, then ventilator will decide if it is a spontaneous breath or if it is coming too close to the mandatory breath time. Every 5 seconds we have to give a breath. So first second and 5th second. If the spontaneous trigger is coming very close to the 5th second, then it will turn into a 500 ml tidal volume. If the spontaneous breath is between the two mandatory breaths, then it will be handled as a spontaneous breath and will be given 15 ka pressure support. So pressure support will be given to the breaths which are between the two mandatory breaths, and if the trigger is coming very close to the mandatory breath, it will be handled as full tidal volume breath. So in ACMV, every trigger was given full tidal volume. In SIMV, the triggers that come between the two mandatory breaths are treated as pressure supported breaths, and the triggers that come during the timing of mandatory breaths are considered to be mandatory breaths. So our patient was very happy and he was very comfortable. So eventually this SIMV plus PSV has turned out to be the best mode to even initiate a ventilation, because if a patient is paralyzed and if you have set like 500 into 12, the patient will be getting full 6 liters of minute volume. So it works as good as a CMV. If the patient starts breathing, then it will start working as SIMV plus PSV. So in a paralyzed patient, ACMV, CMV, SIMV plus PSV, they are all the same. In a spontaneously breathing patient, ACMV might be a little troublesome because it will hyperventilate the patient. In a spontaneously breathing patient, the best thing is SIMV plus PSV. Why? Because SIMV will guarantee the minimum mandatory ventilation of, let's say, 500 into 12, and PSV will make sure that every effort is recognized and respected. Are we together here? Now there are other modes also which I am not going to cover in this class because I'll try to finish this class in like 45 minutes to 1 hour. There are other modes like complicated modes, APR, V and bilevel. But let's understand one more thing, which is an important concept. We decided CMV, SIMV, PSV. इसमें कोई problem हो तो tell me, then I'll shift to a different concept.
Sir, someone has asked, does this mode also has a problem of hyperventilation?
Not really, because this is a weaning mode. So if the patient is breathing very comfortably and if he is breathing too much, you can reduce the number of SIMV breaths.
Sir, one more question. If pressure support breath is at 2 seconds, when will be the next SIMV breath?
Yes, it will reset the cycle. आगे चले?
Sir, many of them has written all fine. We got the modes properly. They have they have
Many of them have
understood,
written.
they have understood the modes, sir. Till now, what you
Right.
have. Yes.
Right. So let's move to another thing. We didn't decide on pressure volume. We didn't decide on pressure control or volume control. They are not exactly modes of ventilation. Now let's understand something different. Your lungs are like balloons. And when you push air into a balloon, or your lungs for that matter, you are generating some pressure on the walls of the balloon or the lungs. Right? Now, whenever your tire gets punctured, your car, your bike, whatever, you go to the mechanic, the puncture wala, and you ask him to fill how much air? What do you ask him to fill? How much air do you ask him to fill? Tell me. Whenever your car tire or your bike tire gets punctured, you go and you ask him to fill some air into the tire. How much air do you ask him to fill? That's a good answer. Right. That will not blow out. You don't do it with lungs, yeah. Up to a fixed pressure, according to pressure. So we ask him to fill maybe like 30 psi, 35 psi, pound per square inch. This air will be different for a bicycle tire and a truck tire. The volume of air will be different for both these tires, but the pressure can be equal. Similarly, your lungs are exactly like balloons and they need to be filled with air. Now there are two ways of filling air in lungs. One is that we can fix a volume and fill the lungs with that much volume. Or we can fix the pressure and fill the lungs with that much amount of pressure. But those two things are different. What do you want to have? So you can either fix the volume or you can fix the pressure. You cannot control both. नहीं समझ में आया? Okay, let's do it in a different way. I go to a shop, a dairy, to purchase curd. Now curd is 115 rupees per kg. Right? Now there can be two situations. Either I can ask him to give me fixed 1 kg of curd and I will give a UPI payment of 115 rupees. Or I can bring a 100 rupees note and ask him to give whatever amount of curd I can get in those 100 rupees. I cannot control both. The rate of the curd is 115 rupees per kg. Either I can fix the amount I'm going to pay and get whatever amount of curd I can get, or I can ask for 1 kg of curd and I'll be happy to pay whatever amount it takes. Similarly, in the lungs, whenever you fill in some volume, you are going to get some increase in pressure. But the amount of pressure you can tolerate, either you can fix that, or the amount of volume you want to give, you can fix that. You can choose between the two, you cannot choose both of them. The resultant will depend on the condition of lungs, what you can say, the elasticity, the compliance, the resistance, but you can choose only volume or pressure. This is what we call as volume control and pressure control. So in volume control, we can decide how much tidal volume the patient will get. We will inflate the AMBU 500. Now somebody with very good, beautiful pink lungs will have his pressure elevated to maybe 14, 15. And somebody with ARDS bad lungs will have a pressure rise up to 55 with the same 500 ml tidal volume. Right? In volume control, we can decide how much tidal volume the patient is going to get, but the pressure generated will depend on the condition of lungs. In pressure control, we can decide how much peak pressure we are going to tolerate, but the tidal amount generated will depend upon the condition of lungs. So in volume control, we can decide the peak pressure generated will depend upon patient's lung compliance and airway resistance. In pressure control, you can decide the peak pressure, the tidal volume will depend upon compliance and resistance. So this is volume control and pressure control. Usually, as they say, in children we prefer pressure control because we don't want to increase the pressure beyond a certain limit, let's say 20. In adults, we are comfortable with volume control and we can get the pressures high up to even 30, 35. Again, there are a lot of other things like plateau pressure and all. Let's not go there. You just tell me if you got this concept of volume and pressure control. So I guess my 1 hour is getting over. The remaining things, things like troubleshooting the ventilator and some scenarios and alarms of ventilator, maybe we can discuss in a separate class. So if you like the class, you can just write happy in the chat box. If you want me to teach for another 5 minutes, maybe I can teach one more mode. Whatever. Sarji. Five more minutes, chalega. So volume and pressure control I taught you. In pressure control, we can decide how much peak pressure we can tolerate, but the tidal volume generated will depend upon the patient's lung compliance and airway resistance. Right. So one more mode I have to teach. There are two types of modes. There are assist modes and there are control modes. Assist modes are tum सांस लो, हम support करेंगे. They are CPAP, BiPAP and PSV. Control modes are when the ventilator says कि मैं सांस दूंगा, your CMV, ACMV and SIMV. Assist mode, तुम सांस लो, I'll support. Control mode is I will give you breaths. So let's learn another mode, which is तुम सांस लो. Some of you might have dogs in their homes and some of you might be taking those dogs along when moving in cars. Have you seen the dogs just putting their snout out of the car and trying to breathe in? What's happening here? Are they liking the air? No, it's different. The dog doesn't want to sit inside the cabin. He wants to put his snout out. Why? Because the dog has a very high upper airway resistance. And when he's facing the air, he's creating a continuous pressure of air on his snout, which is helping him breathe. It is exactly as a ventilator mode. You must have seen when we come out of, let's say, we have done some kind of exercise or a lot of running, we go in and we try to face the fan directly. Whenever we are in a gym and there is a table fan kind of thing or a ceiling fan kind of thing, we try to go in front of that fan and we try to grab all the air in. What exactly is this fan doing? It is putting a continuous pressure of air on your nostrils. How does it help? It is a continuous positive air pressure. This continuous positive air pressure, when you breathe in, it helps with your tidal volume. If you are supposed to take 450, this pressure will push maybe 50 ml more and you will breathe 500 ml. And when you are breathing out, this will work like a PEEP, a positive and expiratory pressure. This continuous pressure, when you breathe in, it helps with your tidal volume. When you breathe out, it works as a resistance and it gives you PEEP. So it is helping both ways. So CPAP mode is like what? When you breathe in a zero air situation, on atmosphere, you breathe in and you breathe out. Let's say we put a fan with a power of 5. Now you are breathing against a pressure of 5 and your inspirations and expirations, they are facing a pressure of 5. This is continuous positive airway pressure. But this will work only in a spontaneously breathing patient. All breaths are to be taken by the patient. The patient breathes against a raised baseline and this helps with opening his alveoli because PEEP helps with that. All breaths can have different tidal volumes. This is a mode for a spontaneously breathing patient. It acts just like a support as a PEEP. So when you are about to extubate a patient, maybe you can put him on CPAP. ठीक है sir? One more mode comes out of this. The patient is breathing either on atmospheric air or against a raised baseline. But maybe we can do one change here. When the patient is breathing out, when the patient is in expiration, we can put a fan of 6. And when the patient is inspiring, we can put a fan of 12. All we are doing is just throwing air onto his nostrils, nothing more than that. But when he's breathing in, we are giving a pressure of 12. But when he's breathing out, we are giving a PEEP of 6. Now, there is one inspiratory positive airway pressure and one expiratory positive airway pressure, IPAP and EPAP. Now, since there are two PAPs, this has become a BiPAP. This same mode can be called PSV when the patient is intubated, and this same mode can be called as BiPAP when you are giving it non-invasively. So the IPAP helps with CO2 removal. It is increasing the tidal volume, increasing the minute volume. It is causing ventilation. It is causing CO2 washout. It is helping with ventilation part. And this EPAP of 6, it is acting as PEEP. It is opening up the alveoli. It is recruiting the alveoli and it is helping with oxygenation. So if you have a patient on BiPAP and his CO2 is high, then probably you want to increase IPAP. If his O2 is low, then probably you want to increase his EPAP. And remember, there should be at least a gap of 6 to 7 between IPAP and EPAP. Right? So this is BiPAP ventilation. It is same like CPAP, but you give different values of pressure during inspiration and expiration. They are called as IPAP and EPAP. IPAP helps in removal of CO2, and EPAP helps in oxygenation. So this is all from my side. It is exact 1 hour. So I would like to take a break here. You can ask me whatever you want to. Any questions so far?
Dr. Manohar Barne has raised hand. You can ask.
Thank you, Mayank sir. The difference between CPAP and BiPAP is that CPAP is running like a constant fan on your face. Like this. This is CPAP. During inspiration and during expiration, you are facing the same flow of air. In BiPAP, during inspiration, you are facing 12 and during expiration, you are facing 6 or whatever the numbers you have put. So it is not continuous positive airway pressure, it is bi-level pressure. Inspiration ka alag, expiration ka alag.
So, Dr. Mohan Pathak has asked, in children, what mode we should prefer? In children, what
In
mode?
children, ये मुझे दिखा नहीं प्रश्न. In children, what is the mode of invasive or non-invasive? In children, we prefer pressure controlled mode, if you are asking that. Pressure controlled mode.
Sir, one more question. Difference between EPAP and IPAP, why it is not less than 6?
हाँ मयंक सर, ये मैं नहीं बताऊंगा, ये आप बताओ.
डॉक्टर सुबोध, इससे पहले कोई बताए, I have to do one thing. I have to go for emergency. Let me felicitate you people before I go. The class should continue with the question answers. ठीक है? So you just continue with it. I will just give me 1 minute for a felicitation of
Yes, sir.
your friend. So I will be sharing my screen for a
Yes,
while,
sir.
and you can switch over to the other one. So, Dr. Subodh, thank you very much for coming to the class.
Thank you, sir. Thank you so much, sir.
So it is always a privilege and our honor to have you in the class and as a good teacher, as a clinical Guruji. I think many of the concept must have got cleared, and recording will be available on the YouTube at ISNHQ after the class is over. So anybody can watch this class later on for the concept. And this is very, very important, and we remember this class for a long time. Thank you, Dr. Subodh, for being for the mentor for this class. And our Kati Lavanya as well as Dr. Farheen, they are class coordinators, and I think they have done the justice, and they will be helping you further also after this deliberation and the question answer. I think all the question and answers, Rahat and Lavanya, kindly see all the chat boxes and keep helping Dr. Subodh so that he will be able to answer everything.
Yes.
Thank you, sir.
So, Subodh sir, you continue with the class. That was my
Yes,
just brief interference here. You continue with the class, please.
Thank you, sir. Thank you, sir. So where were we? Any more questions? या बंद करें, बहुत सारा हो गया.
Sir, can we?
Sir, there will be many questions. You just keep on asking the people. They will be asking many questions. Let them
Okay.
answer.
Sir, Dr. Amruta has asked, can we use BiPAP as a weaning mode?
Yes, you can use BiPAP as a weaning mode. In fact, I would dare say that when you extubate a patient, a difficult patient, then don't extubate him directly to room air. Instead, extubate him to BiPAP. I mean, see, BiPAP you call when it is non-invasive ventilation. You call it PSV when he is on invasive ventilation, just for the sake of convenience. So yes, PSV is a weaning mode. Definitely it is a weaning mode. Before extubating a patient, you should always keep him on PSV. Even after extubating, you can keep him on non-invasive ventilation BiPAP.
There's a question by RG. Can you please explain, sir, use of
PSV in post-op extubation? See, post-op extubation is a different thing. in a patient who was ventilated for, let's say, a pneumonia or a pulmonary edema, he's a different patient. He's extubated after like many hours and all, and his problem was that he wasn't able to breathe before intubation. And a patient in OT, let's say he was for a routine surgery, something like cholecystectomy or something, you don't need to wean him to SIMV, PSV, then PSV, then extubate. Maybe you can just give him a reversal and put him on the bag and you can extubate. But if it was a difficult patient, then maybe, I used to conduct bariatric surgeries. I will put a patient on SIMV plus PSV in OT also, then pure PSV on in OT also, then I'll reduce the pressure support, and if still the patient is having good tidal volumes, then only I'll extubate. So yeah, it depends on the patient. If it is a difficult patient, you can wean him slowly in OT also. You can put him on PSV, non-invasive ventilation. Suman, when do we select CPAP and when BiPAP? CPAP is selected when you just want to give some PEEP to the patient, nothing more than that. You just want to recruit his alveoli, CPAP is good enough. But in most of the cases, plain CPAP is not used. They always use BiPAP. In anesthesia in adults, which mode is mostly used? It is CMV or ACMV. Can we extubate with after SIMV mode? Yes, we can extubate with after SIMV mode. Now, see, when I say SIMV, it is SIMV plus pressure support. Nowadays, plain SIMV mode are not available in ventilators. PCV वर्सेस PCV VG, ये सब बड़ी बड़ी बातें हैं, बाद में करेंगे. Please explain about HFNC or HFNO. Okay, we can talk about it a little. HFNC is nothing but your plain, you can use HFNC in your OT also without having an HFNC machine. HFNC is basically giving 40-50 liters per minute of oxygen through nostrils, right? Now, if you are giving so much of cold oxygen, it can cause damage to your mucosa and everything. So you need to warm it up a little and you need to humidify it. But let's say you are about to intubate a difficult patient, then maybe you can put those simple nasal airways, what you call as nasal cannulas in his nose, and you can crank up this oxygen to more than 15, 20, 25 liters. It will increase your apnea time. It will give you more time for intubation because it will act as an HFNC. So HFNC is something we can use for oxygenation and we can use for ventilation. It comes without the risks of barotrauma, volutrauma things. In COVID, eventually we realized that even better than mechanical ventilation was HFNC. Got it?
Another question is how to titrate
trigger in PSV, not titrate trigger anywhere. See, initially you keep the trigger to approximately 3 minus 3 ka pressure support, you can say. Minus 3 ka pressure. What is trigger? When a patient is trying to breathe. Now, if you set the trigger too high in negative, what will happen? That the patient will have to generate this much of effort to get a breath. If you keep it too low, then even a movement of hair on his chest will cause a breath. So you have to titrate the trigger as per the patient's requirements. If a patient is happy with a trigger of like -3, he is breathing comfortably, then you are fine. So trigger is like flow trigger and pressure trigger. So you have to set it approximately -3 in terms of pressure. So a patient will have to generate at least a pressure of -3 to get a spontaneous breath. If you keep it too high, then he will not breathe at a trigger of even -3. He will have to generate more efforts. So that depends on how fit the patient is. और बताओ, पैरा ऑक्सीजनेशन की प्री ऑक्सीजनेशन? How do we decide that we should use volume control or pressure support? Volume control versus pressure control पूछ रहे हो कि volume control versus pressure support? ये पैरा ऑक्सीजनेशन इंस्पिरेशन मोड वाया नहीं भी है भैया, मुझे नहीं आता. Volume control versus pressure control. When you are too much worried about increasing pressures, then you go with pressure support. Otherwise, most cases, pressure control, otherwise, most cases, volume control is good enough. और बस 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 कुछ छूटा तो नहीं. व्हाट इज एनआईवी हो गया, नॉन इन्वेजिव वेंटिलेशन. सीपैप कब करना, बाईपैप कब करना, बात कर ली. We put trigger 3 to 1. Yeah, no need to put trigger 3 to 1. Difference fix at 6. Why, sir? Okay. So, Ayushi, there is a thing called as driving pressure. The driving pressure is the difference between your EPAP and your IPAP. This driving pressure is the thing that generates tidal volume. So you want to create a driving pressure, that is why you have to keep a gap of something, minimum 5-6. If you keep the gap too less, then the work of breathing of patient will increase. In pneumoperitoneum, which mode to use for anesthesia? You can use volume control with low tidal volumes. How to count IE ratio? Okay. That's a different story altogether. Hey, one more thing, if somebody is still there in the webinar, I have a series of lectures on ventilator graphs and scalars. You can watch that. It is available on YouTube for free, Clinical Guruji. There I have explained a lot of things. IE ratio 2 minute में try करता हूँ. There is a thing called as total cycle time, TCT. A patient is being given, let's say, 12 breaths a minute. 12 breaths means 5 is the total cycle time. Every 5 seconds, 1 breath. 5, 5, 5, 5, 5, 12 5s are 60. Right? In this 5 seconds, let's say the inspiratory time is 1 second. Then the expiratory time will become 4 seconds. The IE ratio will become 1:4. Now you can change IE ratio in different ways in different ventilators. Either you can fix inspiratory time or you can fix IE ratio directly in the ventilator. Right? So you can control inspiratory time, or some ventilators allow directly changing the IE ratio. So how to count? Total cycle time, inspiratory time, expiratory time. You have, in most of the ventilators, you have this inspiratory time mentioned. 1 second, 1.2 second, 0.9 second. The remaining time is expiratory time. So inspiratory is 2, expiratory is IE ratio. If you have to increase the IE ratio, what you can do? वो बात की कहानी है. Please suggest a book for mechanical ventilation. There are lots of books. Maybe Cheng is one, Deshpande is one. और कौन सा था? मैंने चेंग पढ़ी है, देशपांडे पढ़ी, एक और पिल बीम है, बहुत सारे. पर मत पढ़ो, काम की नहीं है. इससे तो मेरे लेक्चर्स देख लो. अब यहाँ से कैसे शेयर करूँ? मेरा YouTube पे ढूंढ लो ना, क्लिनिकल गुरुजी, मिल जाएगा बहुत सारा. वाइंड अप करें? बहुत सारा हो गया. आधे तो भाग गए. अच्छा, प्लेलिस्ट भी डाल दी. लावण्या,
Yes, sir.
वाइंड अप करें इससे पहले कि मुझे जवाब आना बंद हो जाए.
Any more questions? If anybody wants to ask, just check, Lavanya. If anybody wants to ask questions, they can raise their hands.
Modes of NIV I have taught in a lecture. I don't know. NIV is available on my app free of cost. It is a full course on NIV, like 2 hours or 3 hours. I have taught modes of NIV, and modes of NIV are different. They are unusual. So you can watch those lectures on my app.
Anybody in the
पढ़ाया मैंने.
audience? Anybody in the audience wants to ask any questions can raise their hands.
और क्या पढ़ाऊं? ट्रबल शूटिंग पढ़ा दूं? निश्चल?
So they want you to go on actually.
Well,
Go
I have a
on
full
and on
8
like.
hours course on ventilation, so yeah, I can go on.
Anybody wants to ask once more, you can raise their hands actually. They want to put their input also.
डिससिंक्रोनी अ फ्यू वर्ड्स, चलो उस पर बात कर लेते हैं. यूट्यूब चैनल नेम क्लिनिकल गुरुजी. क्लिनिकल गुरुजी. बट या मेरी अंग्रेजी कमजोर है, मैंने सारा हिंदी में पढ़ाया है, पर समझ में आता है. हाँ, डिससिंक्रोनी पे फ्यू वर्ड्स. मोस्ट ऑफ द टाइम द डिससिंक्रोनी इज बिकॉज ऑफ पेन, because of the patient is anxious, and the best thing you can do in case of dyssynchrony is you just put the patient on PSV mode and observe him for 2 minutes. If he becomes too tachypnic, if he is trying to gasp too much of air, then probably your flow settings are less. Maybe you should crank up the flow a little. Usually the flow is 60 liters per minute on ventilator. You have to increase it to maybe 70 or 80 or something. That is one cause of patient ventilator dyssynchrony, that the patient is air hungry. So you have to increase the flow. Flow और टाइमिंग का क्या रिलेशन है? इंस्पिरेटरी टाइम का, कि your flow is 60 liter per minute. That means 1 second में 1 liter. That means half second में 500 ml. Right? So how quickly you are giving the air in is your flow rate. Sometimes the patients are too much air hungry and they want it very quickly. Like these days, Guillain-Barré is going on as a thing. So in Guillain-Barré, you need to have more inspiratory time, contrary to the common views. Similarly, whenever a patient is air hungry, you have to increase the flows most of the times. ठीक है? And then what you can do is डिससिंक्रोनी में और क्या करेंगे? अभी के लिए इतना ही ठीक है. How to reduce the rate or tidal volume in SIMV and then put on CPAP PSV. चलो ये भी बात करते हैं. Let's say you are ventilating a patient on 500 into 15 ACMV. He starts taking good breaths. Now you put him on SIMV. You will keep the settings exactly same as ACMV. ACMV was 500 into 15. You will put SIMV 500 into 15. Then maybe every hour you will reduce 2 breaths in SIMV. ठीक है? तो SIMV 15, SIMV 12, SIMV 10, and you keep a fixed positive pressure PSV of 15. So 500 into 15 ACMV, SIMV 500 into 15 plus 15 का pressure support. Then you reduce the SIMV rate, you don't touch the PSV. You keep bringing down the SIMV rate from 15 to up to 7 or 8. Once the SIMV rate comes down to 6, 7, 8 and the patient is still having enough respiratory rate on his own, then you can switch him to PSV from SIMV plus PS. Now your PSV is 15 and he is breathing all by his own. Now you keep decreasing the PSV by 2 per hour, let's say. So your PSV was 15, 1 or 2 hours later it comes down to 13, 1 or 2 hours later it comes down to 12. You keep watching for tachypnea, tachycardia, hypertension or any kind of distress. If there is no distress, you keep bringing down the PSV from 15, 16 to up to 10 or 11. Beyond 10, let's say the pressure support is 10 and your PEEP is 5, don't go any further, you can extubate from there only. Right? Don't put a patient on T-piece to extubate. I personally don't recommend it, because in T-piece you don't see any numbers on the monitor. It is better to extubate a patient from PSV rather than T-piece. और कुछ? और पूछो.
Sir, one of them asked to explain regarding apnea ventilation.
एपनिया वेंटिलेशन मतलब क्या? What in apnea ventilation? HFNC thing. एक बार और एक्सप्लेन करना भाई.
Justy has written apnea ventilation explain.
एपनिया वेंटिलेशन एक्सप्लेन HFNC. जितना छोटा क्वेश्चन उतना छोटा आंसर.
So Dr. Muthukumar has asked, how do you advise spontaneous breathing trials? Do you advise spontaneous breathing trials?
Yeah, I do. Okay, without intubation for those who microlaryngeal surgeries and all, again HFNC. I mean, they have said that you can keep a patient apneic for like even up to 12-15 minutes if his lung conditions are good.
Go to the next question, Dr. Lavanya.
Ma'am, almost everything was answered. Now recent.
What mode is PSV plus CPAP mode on trigger machine?
नहीं याद मुझे.
Explain, sir.
HFNO should not cause pneumothorax.
So someone has asked, when patient is on SIMV PSV mode and mechanical ventilation increases to 8 liters, what should be done?
When patient is on SIMV PSV mode and MV increases to 8 liters, what should be done? Either you can decrease SIMV rates. If he's already, let's say your SIMV rate is 15 and he's breathing at 20, then probably he doesn't need your SIMV rates. You can come down on SIMV rates. If he's still breathing very good, then maybe you can come down on pressure support also. बस करें. सिडेशन के एनएमबी एजेंट यार ये मत पूछो. एनेस्थीसिया वाले हो सारे. आईसीयू वाले पूछे तो ठीक है. Elective ventilation criteria for bariatric patients are different. In bariatric patients, your normal CO2 values and acidosis values, they don't work. So it is like tricky, it is patient to patient, because if you put a patient on ventilator and you try to chase normal values, he will never come out. उसके लिए तुमको इंदौर आना पड़ेगा सीखने. लंग प्रोटेक्शन वेंटिलेशन पीक प्रेशर्स ज़्यादा नहीं जाने चाहिए. प्लेटू प्रेशर्स शुड बी लाइक अंडर 30 and you increase the respiratory rate to generate minute volume. You tolerate some kind of hypercapnia. How do we decide for the pressure in pressure support ventilation? Yes, you decide for pressure in pressure support ventilation by observing how much minute volume he is generating per minute. Right? What is his effort? What is his rate? And based on that, how much minute volume he's generating. Let's say he's breathing at a rate of like 20 and he's generating tidal volume of like 200, 250 or something with your pressure support of 12. Then probably you need to increase the pressure support so that his tidal volumes come in the range of like 400, 500 and his respiratory rate comes down to 12, 13, 14. Can we extubate on SIMV? Yes, you can extubate on SIMV.
So Dr. Muthukumar has asked, lung protective ventilation and how to set
समझा
it
दिया.
up in different modes. Oh.
लंग प्रोटेक्टिव समझा दिया. प्लेटू प्रेशर्स कम रखना है, टाइडल वॉल्यूम बढ़ाने हैं, हाइपरकेपनिया टॉलरेट करना है. There is one interesting question. Will patient on SIMV PS with shallow rapid breaths more than saturate will act as PSV? Can there be hyperventilation? Yes, there can be hyperventilation. And then you have to look at your strategy, what's exactly going on. Why is he so tachypnic on your SIMV PS? Probably your PS is not enough. Lavanya, wind up करें?
Sir, thank you very much. Can I ask one question?
Please,
This
please,
is
ma'am.
not for me, but for the benefit of the beginners, that when we change the mode of ventilation, how much how much time will
15
it
minutes.
take? 15 minutes. And when should we ask for an arterial blood gas analysis?
At least it takes like, see, इसको ऐसा कहते हैं कि जैसे the moment you put somebody on ventilator, you don't send an ABG. You need for the things to settle down. This settling
Yes,
down comes
exactly.
approximately at 3 vital capacity, at least 3 vital capacities. But
Yeah.
that is like 2-3 minutes or something. So maybe you can wait for 10-15 minutes for things to settle down and then send an ABG. Do not judge anything in like 2, 3, 4, 5 minutes. Like you
Yes.
put on ventilator, you send an ABG. No, you don't do that.
Yes,
You
yes,
wait for good 10-15 minutes, then you send an ABG.
exactly, sir. I think we were also taught that once you change the mode, you have to wait and watch the patient rather
हाँ,
than go off for a cup
look
of
for
coffee.
clinical signs rather. I mean, look for
Exactly.
tachycardia, look for tachypnea, look for any kind of distress.
Exactly. So we have to wait and watch and then take a call on that. We cannot just walk
Yes,
away
ma'am.
after changing the mode,
Yeah,
because the
exactly.
body will take some time to adjust to the new mode.
Exactly.
Any other questions, Dr. Lavanya? If there are no questions,
Ma'am,
any other inputs from the audience?
sir, one of them asked, shall we use BiPAP at home for interstitial lung disease? If we are using, how to do?
At home,
Hmm.
BiPAP at home, they have asked. And ARDS also few ventilatory settings somebody wanted.
ये हम अगली क्लास में करेंगे सिनेरियोस के साथ में.
Yes. Yes, sir. So if nobody wants to add further inputs, Dr. Rahat, have you seen the chat box? All clear?
Yes, ma'am.
Okay. We have been told to wait for 2 hours after changing the mode. Is there any benefit for waiting for this long, sir?
Not for 2 hours, ma'am. Not for 2 hours.
Correct. You gave the answer just now, sir. 15 minutes.
Someone has asked
Ventilatory mode for
about-
COPD. Again, COPD and asthma ventilation, they are totally different things. They will need their own lectures.
I think COPD, obesity, ARDS, all these will require special scenarios.
Yeah, so maybe we'll have a class based on scenarios के ये है इसको कैसे करेंगे, and maybe we can have an interactive discussion.
Yes, because the clinical parameters also are important over there, isn't it?
Yeah.
Yeah. Next class, we'll let you know. I think somebody's asking when is the next class. We'll get back to you. Okay. So if nothing is there, thank you, sir, for the excellent
Thank you, ma'am.
class.
Thank you so much, ma'am.
Thank you, sir.
And do you want to summarize? Any summarize? I think the basic modes have been covered, and but I think it's such a complicated topic that even the most seasoned intensivist and anesthesiologist do have a tough time sometimes choosing the mode, and the patient also in adjusting to the different modes, and the final outcome is you should have good patient recovery, isn't it? And safety of the patient is also very important when you choose the mode. So, sir, thank you very much for that excellent class. As usual, whatever we expected, it has been a very informative. And thank you to Dr. Lavanya. Thank you to Dr. Rahat for being the screen coordinators. And thank you to my co-coordinator, Dr. Ridhima Sharma. And I think we'll end the class. Thank you, audience. And we'll end the class by saying, I think Mohan Pathak sir has raised his hands. Sir, please. Mohan Pathak sir, do you want to say anything? Please speak. Dr. Mohan Pathak, please unmute yourself. Dr.
Yes,
Mohan
yes, yes.
Pathak,
Hello.
please unmute yourself.
Hello.
Tell me.
Hello. Hello.
Yes, sir. Yes, sir. Please.
Madam, very simple question. Very simple question. During laparoscopy surgery, what should be the usual mode of ventilation? Laparoscopic surgery with pneumoperitoneum, head low position and all.
Routine
Okay.
volume control, sir.
Volume control with
Routine volume control, maybe with a lower PEEP.
lower PEEP. Okay. Thank you.
Yeah. So I think if that is clear enough, we'll close the class by saying long live ISA. Good night.
Good night.